Welcome to the virtual trauma meeting. The aim is to provide a friendly environment for open case-based discussions with the help of orthopaedic trainees and consultants to build upon orthopaedic knowledge and experience for undergraduates. John, please could you present the case for us?
This is a 76-year-old lady who's coming with a left distal radius fracture. She tripped on a curb while shopping and fell onto her outstretched hand and then went into ED with an obvious deformity of her wrist. She has no other injuries. She's otherwise fit and well, independent at home, no package of care, and walks without a stick, still does her own shopping. On examination, it was a closed, neurovascularly intact injury, and it had been manipulated into a below elbow back slab. My main concern would be that she had no other injuries. So I'd want to make sure she hasn't banged her head or injured her neck and really thoroughly check for other injuries. Often they could have an injury of their ankle or their lower limb as well. When I assessed the patient, I'd make sure it was a closed injury, so the skin hadn't been cut. Often you do get grazes and you have to look at them very carefully to check it's not actually from the bone poking through the skin. And then I'd want to check the nerves of the hand, most importantly in the distal radius, the median nerve, because that runs just on the palmar side where the fracture is and can often be bruised and stretched.
My neurovascular check, I start by looking at the hand. Does it look pink? And then I feel whether it's warm and well perfused. I then move on to checking a capillary refill. So I press in the fingertip for 5 seconds and then let go and count the amount of seconds it takes for it to go pink again. And it should be less than 2, ideally. Then I'll feel, if possible, if it's not obstructed by a cast, for a radial pulse. So that's the vascular check. Next, I'll move on to the sensory check. So I'll touch here, which is the anatomical snuff box, and that's the sensation to the radial nerve. Then I'll touch here, the border of the index finger, and that's the median nerve. And then I'll touch here, which is the border of the little finger, and that's supplied by the ulnar nerve. So that's sensation. Then finally, I assess motor function. So I ask for a thumbs up, and that's extensor pollicis longus, and that's supplied by the radial nerve. Other radial nerve tests you can do are finger extensions, that's extensor digitorum, as well as wrist extension, which is the extensor carpi muscles. So next is the median nerve, that's specifically the anterior interosseous branch of it. So I ask them to make a perfect circle like this. So a perfect circle is testing the flexor pollicis longus muscle, which is this, which is the thumb IPJ flexion interphalangeal joint, and the flexor pollicis longus inserts into here, and that's supplied by the anterior interosseous nerve. And then this one as well, which is flexion of the index finger at the distal phalanx, which is the insertion of the flexor digitorum profundus muscle. So that combined makes a perfect circle. Often, if the AIN or median nerve is compromised, they'll do that. If that's not normal, they have to be able to make a perfect circle. And if you're not sure, you can test it to see whether they can resist that to stop you breaking the circle. So that's the median nerve. And then finally is the ulnar nerve, so the intrinsic muscles of the hand. The easiest one is, can they cross their fingers like that? If you're not sure or they're a kid, you can ask them to make a starfish. And another test you can do is to ask them to make a pair of scissors and try and chop off the end of your finger like that. So that's all intrinsic muscles of the hand. And then finally, can they straighten their fingers? Can they make a fist? That's just checking that there's no significant ischemia or compartment syndrome in the forearm. So if they had compromised compartments, that would either be very painful or they'd be unable to do it. So that's my neurovascular check.
So the main thing that's wrong with this x-ray is if you look at the lateral, which is the right-sided image, you can see that the bone, which is the radius in the forearm, it almost looks like a cup and a saucer, which is the wrist joint. and that cup is pointing backwards to the back of the hand. And the reason why we worry is that you get weakening of the muscles and the tendons around the wrist, and you lose an element of the range of motion. Especially in elderly patients, the main thing is activities of daily living. Grip strength is really important for a number of things. So that's the main deformity. Also on the AP, it does look short, so it looks like the bone is crushed down. So I'm comparing it to the ulna, which is the other bone of the forearm. But if you look at it on the lateral, you can see that there's overlap of the cortex, which is the hard bit of the bone, at the back. So you know that it's narrowed down there. And I think there's also a bit of overlap at the front as well on the lateral. You can see that reflected in the AP with a more dense shadow, so it's more white.
This is a fracture line here. And then this density, where I've drawn the arrow, what we're looking at there is this bit here. And so we know by definition that that's going to be short. And what do you think of the reduction?
So I actually think their reduction's good. I think they've restored the length on the AP and the inclination. They've got it into neutral on the lateral. However, I think in view of the dorsal comminution, this may well displace. So I'd want to keep a very close eye on it in terms of follow-up and get the patient back in a week's time with repeat x-rays.
Excellent. And is there anything looking at those post-reduction films? Are you happy with the cast?
I'd say reasonably, but you're looking for 3-point fixation, and where the fracture is, you've got nice moulding dorsally, which is where the direction it's going to displace into.
So the other things you talked about, John, was the tilt and the inclination. So we've looked at this inclination there and the height, and then the tilt is on the other side. And you called it a dorsal angulation, didn't you?
Yeah.
So we've got dorsal on this side when we're talking about the hand and wrist, and volar on this side. This is the thumb here. So we know this is the front, the volar side, the anterior side, but we call it volar. And this is dorsal. And so the direction of travel of this fragment of bone is dorsal. Okay, so looking again at the AP, the front-on view, and the side-on view, the AP and the lateral, and you can see that the height of the radius on this screen compared to that screen is higher. So that's what John was referring to about they've improved the height. They've also improved the overall angulation, so it's a bit more of a straighter line, whereas here it kinks like that. And that's what people classically talked about as a dinner fork deformity. So, John, what do we normally do once you've manipulated a fracture like this? What sort of cast do they go into?
Mostly it's a back slab. And what we mean by a back slab, it doesn't necessarily have to go on the back of the arm. It just can't go circumferentially around the entire arm. And the reason why we do that is so when this injury swells, which will be within the first 48 hours, there's some space for it to go and you don't get a really nasty, tight cast.
For the keen-eyed amongst you, you'll have noticed that actually this is a complete cast because it's got on the AP and the lateral cast all around. So this probably wasn't the cast that she had put on after her reduction. This is probably being completed later on. Moving on to the management, how we're going to treat this injury. What are the different options for treatment? And at this point, I'll put it to the floor. Has anyone got any ideas about how we might treat this injury? What other factors we might be thinking about in terms of this injury? It's a low energy injury. So first of all, what might we be concerned about as an underlying diagnosis? And second of all, how might we treat it?
It is a Colles fracture.
Yep, that's it. Exactly right. Yep.
And so in order to fix it, you would apply traction and kind of just put the bone back in its place.
Yeah, exactly right. That's exactly what we're intending to achieve by reducing it. And essentially, you're reversing the deforming forces. So this lady has fallen onto an outstretched hand. She's hit the heel of her palm on the ground, and it's basically pushed the bone backwards. Now, that doesn't happen. If you or I fell over, we probably wouldn't injure ourselves like this if we were just walking along and tripped over a curb. Why do you think she's done this? Why do you think she's injured herself at the age of 77?
Is she osteoporotic?
Yeah, she may well have osteoporosis. Now, she might come in having been diagnosed with osteoporosis, but we would certainly suspect that this is a fragility fracture. And so we'd need to confirm that diagnosis. We can't do that by looking at x-rays. The diagnosis of osteoporosis has to be done by a DEXA scan. There's a definition for what it is on DEXA scan. The other thing was whether or not she has had any previous fractures. because if you've wired one fragility fracture, the chances of you having another fragility fracture are quite high. The next question goes on to how are we going to manage this fracture? So you talked about the initial management in terms of reducing it and putting it back, and that's what's taken place. What now? Are we going to leave it like this, or do we need to do anything more? Would you be happy to leave it like that?
Would you need to do some surgery on it, just because it's got a lot of pressure going through the area?
Well, what are you worried about from a pressure point of view? Are you worried about pressure on nerves, or are you worried about pressure on the bone?
Pressure on the bone where the fracture is. Okay,
so you're absolutely right to be concerned about that, because where she's likely to collapse, if she does collapse, is in here. Okay, there's some dorsal comminution, and I presume what you were referring to.
Yeah.
This could collapse back like that. So what we want our cast to do is to put pressure, to push it up in that direction, to stop that from happening. It will either stay in that position, it will fall off the back into the position it was initially, or it will fall a little bit back. And the time is the great factor in the treatment of a lot of these injuries. So this is how she is early on maybe day 1 or 2. We would probably x-ray it again in 2 weeks to see what happens. Does it displace? Does it fall back again? Or does it stay there or thereabouts? And what we know in this age group is that actually whether you treat them with an operation or not actually doesn't make a huge difference to their outcome. At 2 years, their functional outcome, they can actually achieve the same things at 2 years, whether you treat them with an operation or whether you treat them with a cast like this. And that's the importance of long-term studies. The only thing you have to warn them about is that their wrist will not look the same as the other side. And I remember saying that to a lady once, and I said, it will not look the same as the other side. And then she showed me her other wrist, and he said, what do you mean, like this? And it was exactly the same. And she said, I'm so glad I never had an operation. It doesn't look right, but it works absolutely fine. And she has avoided all the risks of surgery in terms of infection, bleeding, nerve or blood vessel injury, having a general anesthetic, all of those things. This whole area has got a little bit more complicated in terms of there are now nice guidelines for the management of these injuries. And so there's a very easy pathway to follow. You perform the initial reduction, you x-ray it at 2 weeks. If it's moved, you offer the patient manipulation plus or minus a wire to hold it, to provide some extra support. And if that doesn't hold, then internal fixation. But it's always reassuring to be able to tell a patient that at 2 years, their outcome will likely be the same, whether or not they have an operation or not. Any questions on that?
So if they were younger, would you be more inclined to do the ORIF that you're on about, or would you want a cast?
As I'm sure you'll know, an ORIF is open reduction internal fixation, where you make an incision, you reduce the fracture and get it anatomically reduced, and then put a plate and screws or use other form of fixation. So in a younger patient, it's more likely to be a higher energy injury. So the chances of them displacing would be much higher. So your open reduction internal fixation would minimize the risk of them displacing.
Do you only use an ORIF when it has displaced?
Generally speaking, yeah. There are other types of fracture which we know are more likely to displace. This isn't one of them necessarily. And this, if it can be made stable in a good cast, then it can maintain its stability and keep its position. But yeah, you normally reserve open reduction internal fixation for the less stable fractures. So we've got a few things to remember. So we talked about describing the distal component of the fracture in relation to the proximal bit, dorsal angulation, to reduce the fracture into a satisfactory position, and then hold it in that position until it heals, okay? And in this case, it can either be achieved with a cast or with internal fixation. Okay, now the median nerve we talked about at the beginning, and John did a very nice demonstration of how to assess it. The median nerve travels along the front here. Basically, it's coming up here. And if you look at that on the first view, you can see there that there could be pressure on that nerve. So that's why it's important to assess it. And if that fracture displaces further, then they could end up with a problem with their median nerve. For two reasons. One, you've got the direct force of the fracture. So you can see that bone is sticking up, could be applying direct force. But also, as we all know, when you get a fracture, you get inflammation. You get a big inflammatory response related to a fracture. And so At this point here, the nerve goes through the carpal tunnel, which I'm sure is a term you're all familiar with, the carpal tunnel, where the median nerve enters the hand at the level of the wrist. And if it's a contained space, and if you get swelling and inflammation inside that space, that can affect the nerve. It can lose its blood supply. It can be very, very painful, and it can stop the nerve from working. So that in itself is a surgical emergency and requires urgent decompression. It's a rare occurrence. It's generally associated with higher energy injuries. It can occur in these, but it's rare, but it's the sort of thing that can easily be missed. And so although it's rare, the consequences of it are severe. So loss of median nerve function is a big issue functionally for the patient. And so therefore it's something you need to look out for.
Thank you for listening. We hope this has been informative. If you have any questions or suggestions for further programmes, please contact us at thegrandacademy@btinternet.com.